Hi guys! So for those of you who don't know me, I'm Shreen and I am known for making these beautiful posters on pretty much everything. So I've made a few on oral med and I thought like why not just throw a little crash course on what I know. And it might be helpful for those of you either just starting off or just reviewing really. So I've basically put down white lesions first. We'll do white lesions first and then carry on and see how many I can do. I learned from teaching, so it kind of works. So white lesions can be split into four things. So we have local factors, which is typically trauma, and then congenital white lesions. Then we have inflammatory white lesions, which is split into infective and non-infective. So infective being like bacterial, fungal, viral, and not the non-infective ones, are like the lichen planus and whatnot. And then we have this section here, which is on like precancerous lesions, but there's a whole nother poster on that, so I won't go into too much detail. So to start off with, the really easy one is trauma. So these ones are like occlusal trauma, which you'll find that white line on the cheek. Oh, also disclosure. Most of this is from referencing? I don't know. Most of these are from basically Odell's book, and then I think I mix it up with like clinical dentistry and just a few other books. I don't have pictures, I'm sorry. Maybe I'll like edit the video when I'm free post exams and add photos with it as well. But point is, it's just really quickly summarizing white lesions in the mouth, characteristic features, and then ensuring that like if you were to be asked about like differential diagnosis, you know, okay, based on location, based on presentation. So just key features about all of them, and then yeah, it's just revision really. Okay, going back. So local factors, we have I said occlusal trauma. You have, so that's linea alba, and then you have materia alba, which is basically debris, so it should be wipeable. So it's a white lesion that is wipeable. Not really a lesion, but okay. But I think you get burns and then like graft scars. So these are all, trauma related. And then keratoses. So you have two main ones. So frictional keratoses, which is typically sharp tooth, denture clasp. You're looking for stuff that are causing trauma in the mouth. Typically found, I think, occlusal plane and lateral border of the tongue. And then you have your smoker's nicotina, so the smoker's palate, which is just on the palate. You get these white lesions, so it's like white circles with red dots in the middle. And that's basically your minor salivary glands that are inflamed. Right, so obviously smoking causes it, and typically pipe smokers. So that's local one. Management is just treat the underlying cause. It should go away. If it's persistent for more than 3 weeks, you start to question it, biopsy it, might be precancerous. Okay, congenital white lesions. Four main ones that I'll talk about. Most of these are like congenital ones. You'll find most of these are either present or they develop. But they will be symmetrical, like they'll be bilateral and symmetrical. So you have Fordyce's spots. These are ectopic sebaceous glands, and they're typically found like buccal mucosa, inner side of the lip, and they're just these white creamy spots. And like because of the fact that they're symmetrical and they don't really look that dangerous, it's clinically diagnosable. So, not an issue. Leukodema. So this is typically present in African, Asian ethnicities, and it will be like a grayish white film on the buccal mucosa, but the important thing about this one is that when you stretch it, it disappears, and this is because, so edema is like full of, like, there's water in it, and it changes the light reflection, one of them, and that's what causes the change in color. So you stretch it, it goes away, leukodema, not an issue. Again, bilateral and symmetrical. Next one, there are two types of inherited disc keratosis. So these are, again, as it's in the congenital section, so inherited. You have white sponge nevus. This is the really disgusting looking one. It's like on buccal mucosa, typically, again, bilaterally. But it can present everywhere else in the mouth, and it's like these corrugated, like really white, thick, folded in the mouth. And most important one about this one is that you check for a family history. Typically there is a family history, it's present in childhood, and again, treatment wise, just reassurance, but you can biopsy if in doubt. But that family history is, I think, the most important one about this. And then the next one is, I don't have it up here, unfortunately, but it's there. Disc keratosis congenita. This is, I think, the only congenital lesion that is potentially malignant. So it's found in the mouth. It's like white, mixed red and white lesion. Are other things about it, but on biopsy there is signs of dysplasia, and it is potentially precancerous. So if that one, I would always include in any sort of white lesion differential diagnosis. I'd put it in there, just in case. I'll go into inflammatory later because that one's a bit long, but we'll start with this precancerous ones. So the precancerous ones, we have, it's just a list, there's a whole poster on it, we'll go through it afterwards, but there's like submucous fibrosis, so that's under the tongue, and then you have your persistent keratoses, so like a persistent trauma because of a tooth. Our communication exam had that example, the oral cancer one, right? Oh, my tongue has an ulcer, my tooth is sharp, and you check there's no sharp tooth, but there was one in the past, but it was treated, but that just instigated a squamous cell carcinoma in that area. So it can, so frictional keratoses can be, if persistent. Submucous fibrosis, we have that one, the disc keratosis congenita, and then one that you'll find here in the fungal section is Candida leukoplakia. But essentially these are all names for lesions after you biopsy and you figure out what it is. But they'll usually present as this idiopathic leukoplakia. So this is a white lesion that doesn't fit anything else, but it's there. And you're like, I don't know what this is. I can't put it into any other category, so I'm just going to call it like a I don't know white lesion, so an idiopathic leukoplakia. Most of these are benign, so 70% are benign. However, there are certain factors that will make you think, oh, it could be precancerous, and this is all like, you know, risk factor assessment. So look at the patient's history, their smoking, alcohol, tobacco use, and then you look at the actual clinical presentation. So if it's speckled or nodular verrucous, where it is, so if it's in a high risk site, so this area, so under the tongue, so ventral tongue, the floor of the mouth, the lingual alveolar ridges, and then the retromolar pad area, and then back towards the oropharynx and the posterior lateral side of the tongue. These are all high risk areas, and so if you find a white lesion that doesn't fit anywhere, that is in that site, you're like, it could be cancer. I'll biopsy it. I found dysplasia. Too bad. Right. So also you want to look for rapid increase in size, rapid change in color, any ulceration. Pain is usually late presentation, but still ask. And lymphadenopathy is probably the most important one. So these are all just indications for biopsy. And there's one more. Oh, association with Candida. We'll get to that when we come here. And then down here at the bottom, I have oral squamous cell carcinoma. So we know this, okay. Usually present in the, again, high risk areas. and you'll find like a persistent ulcer that's been there, it bleeds spontaneously, it's hard, it's indurated, it's fixed, clinical presentation really, and then history as well, history of smoking, tobacco, alcohol use, and you biopsy it, you find dysplastic, like dysplasia, and in carcinoma you'll find two differences, like two main differences in the histology. So just, again, it's in the other poster, but I'll just drop it here. In these idiopathic leukoplakias, if there is signs of malignancy, you'll find dysplasia, so a mild, moderate, severe dysplasia, and that will typically be weirdness in the epithelium. So you'll find either increased thickness. You'll find typically with white lesions anyway, you'd find increased keratin because that's what makes it white. Change in the, I think the main ones that I always think of is, okay, normally you have a basal layer, it's just one layer. If you have multiple, problem. If you have mitoses occurring not just in the basal layer but somewhere else in the middle, problem. Because there's like rapid, like what do you call division, in, as you do in malignancy, rapid division, you'll find lots like dense DNA, and DNA always stains dark on a histology slide, so you'll find that it's generally much darker, so hyperchromatism, so darker staining of the cells. You'll find weird shapes of the cells, so anisonucleosis, I think that's like different sized nuclei, and yeah, all of that you'll find like in dysplasia, and you'll also find like really deep like rete ridges. But the things that differentiate like dysplasia from carcinoma will be the islands of epithelium, so like you'll find invasion. So it passes this critical line. So normally all the rete ridges will be like this, and then suddenly there'll be like this massive drop, and it probably like teardrops, and it sections off into an island that is invasion, carcinoma. Or you'll see that those ridges are going deep into like muscle and nerves and whatnot. Invasion again, carcinoma. And keratin pearls, you'll find just like these pink circles somewhere randomly in the connective tissue. It doesn't make sense, shouldn't be there, but it's there. It's carcinoma. Okay, separate poster though. Lastly, inflammatory section, so inflammation can cause white lesions, and split into infective and non-infective. So the infective ones split into bacterial, fungal, and viral. And your bacterial one, really, it's not much to talk about. It's very rare, syphilitic leukoplakia. It is a precancerous lesion. But I think like, yeah, the main features in the mouth you'll find are like these snail track ulcers, and yeah, ignore that one. That one's really boring. Fungal infections. So Candida. So we know Candida is an opportunistic infection, and there's usually so many predisposing factors which would cause an opportunistic infection. So immunosuppression is probably a big one. Immunosuppression, xerostomia, poor hygiene, anything that causes xerostomia, sorry, so like radiation, old age, polypharmacy, Sjogren's, and poor hygiene, denture, yeah, like keeping your denture in at night, so poor denture hygiene, and then also like anemia and diabetes and increased antibiotics, because I think you destroy the bacteria and then you allow like the fungus to just take those spots, and that's what causes that opportunistic infection. And then all the immunosuppression diseases like HIV, leukemias, and like cancers. Anyway, so Candida albicans is your fungus. It is an opportunistic growth. You confirm it in the lab, so smears, swabs, oral rinses, cultures, the whole thing. Main important thing is like how to remember and how to differentiate between all the different candida lesions. So you have 3 white ones and 5 red ones. So 3 white ones, 5 red ones. White ones can be split into this. So we have general oral thrush, that will be everywhere, and is scrapable. Okay? Then you will find CHC, so oh my gosh, chronic hyperplastic candidosis. So that's in the post-commissure, like post-commissure of your buccal mucosa. There's a white lesion, corrugated, typically in smokers, and it's not scrapable. So thrush, scrapable, CHC, not scrapable. And it's a very typical site, like that's where it typically happens. Can also happen in the lip, I think, or the like other buccal mucosa, but typically it's that post-commissure area. Very important though, even though you can diagnose it and be like, okay, because of the site, because of the history of smoking, and because of the way it looks, it's CHC. However, there is a precancerous lesion that does present exactly the same way, or very similarly, and is called candidoleukoplakia. So it's a leukoplakia associated with candida, which, as we said, was, increasing the risk of malignancy. So you should always biopsy it. You biopsy it. If you find dysplasia, it's candidoleukoplakia. If you don't find dysplasia, it's CHC. But at least you ruled it out. So yeah, those are the 3 ones. So white, so thrush, scrapable, CHC, not scrapable, but indistinguishable from candidoleukoplakia. So you biopsy it anyway, and you make sure there's no dysplasia. Moving on, 5 red lesions. So you have antibiotic sore mouth. It would be red, but you'll find history of antibiotics. There will be there's denture-related stomatitis, so it will be in the shape of the denture, typically in the palate because it's drier. And then you'll find erythematous candidosis. So this it causes like redness in the palate and the dorsum of the tongue. Is typically associated with HIV. So again, you like diagnose that candida from the history of HIV. Angular cheilitis. So you'll find folds here in the corner of the mouth, difficult to clean saliva pools. Any fungus in the mouth actually comes out and it creates lesions here. Again, very easy to distinguish just from the site. And then median rhomboid glossitis, so it's a red patch at the dorsum of the tongue, surrounded by white, and usually you'll have a kissing lesion because every time your tongue touches your palate, it just spreads. Yeah, so that's the best way to remember: 5 red lesions and 3 white lesions, and then just their associations, like the main associations. Next is viral. Not all of them present with a white lesion. I put it here just because it's summarized really nicely. Essentially, there are like 5 herpes-related viruses that you want to know. Herpes, so HHV, so herpes, human herpes viridae, so HHV1. I think this one's herpes simplex. So the primary infection will be this primary herpetic gingivostomatitis, typically in children. Be ulcers around like the gingiva, and pretty much anywhere in the mucosa. It causes lots of fever. They don't eat and they come in. It's really infectious. So you give them acyclovir. A lot of these ones, you give them acyclovir in the beginning. It works. Later on, you just suck it up and you let it just sort itself out. Then there's no such thing. Okay, there is such thing as HHV2, but it's not related to us. It's more of a genital problem. So it's HHV1, and then there is a reactivation of it. Reactivation typically is because of like stress or immunosuppression. You get herpes labialis, so you get crusted lesions, crusted ulcers and lesions on the lip. Then you get HHV3, so this is a herpes zoster. Again, it's latent in your trigeminal ganglion, I think for those who have had chickenpox, latent in the ganglion, and then it will reactivate and it will spread down any dermatome, so very rarely the ophthalmic, but typically maxillary or mandibular. and it will only affect that dermatome. So you'll find ulcers just on that side. It'll be a rash just on that part of the skin, wherever the dermatome is. Be very painful. But again, treatment in the beginning. Otherwise, let it heal itself. Very infectious. Avoid. HHV4, Epstein-Barr virus. So this associated with HIV. So when HIV becomes AIDS, typically you'll get a large increase in Epstein-Barr virus, opportunistic, and you develop hairy leukoplakia. So the lateral side of your tongue, you get these like vertical corrugations. So any differential diagnosis on white lesions of the tongue, which we will do also, is hairy leukoplakia. Put down hairy leukoplakia is not necessarily that. It's not precancerous. It's not. It's just because of Epstein-Barr virus. And then lastly is HHV8, which is Kaposi's sarcoma. It's not white, it's purple, and it's malignant, and typically found in HIV. Again, it's an HIV lesion. So then the last two we have is like Coxsackie, so hand, foot, and mouth disease. I think you get like vesicular eruptions in the mouth. And then last one is HPV, so you get the papillomas, I think the retromolar area. But then there's certain genes that are associated with oropharyngeal cancer, so genes 16 and 18, HPV 16 and 18. But that's again separate topic. Lastly, the non-infective white inflammatory lesions is lichen planus, lichenoid reactions, and lupus erythematosus. In summary, lichen planus is typically bilateral, is usually symmetrical. Lichenoid reaction, unless generalized, if it's a local one, it will be asymmetrical. And then lupus erythematosus will present like lichen planus in the mouth. However, there are other systemic lesions as well, so you always want to check for rashes, so skin rashes, and like other autoimmune diseases like Sjogren's and joint problems, maybe. Anyway, so lichen planus, so as we said, typically bilateral, mostly present in the buccal mucosa, sometimes the gingiva. There's 6 different types. So reticular, white striae. Every time you see striae, always just think lichen planus. You'll find plaques, so white patches. And then you have papular, so white spots. Atrophic, which is a diffuse red lesion, and it's associated with desquamative gingivitis. You'll see that word a lot. It's just a presentation, really. It's not a diagnosis on itself. It's not a disease on itself. It's a presentation in certain diseases. Most common cause is lichen planus. Atrophic lichen planus. Then you have erosive, which is now known. Prof. Odell prefers ulcerative lichen planus, and as the name suggests, it produces ulcers and like fibrinous yellow sloughing. And then you have bullous, so blisters. Those are the 6 types. Typically, from my understanding, is that most of them will present on a reticular background, so like on those striae background. And then what you would suggest is that, if you're doing like a differential diagnosis, you would also say, I would also check any flexor surfaces of the skin, so like shins and wrists, for 4 P's, okay? So purple, papular, polygonal, pruritic, so itchy, lesions, because it's a typical sign of, like, extraoral signs of lichen planus. Histologically, lichen planus and lichenoid reaction will all have the same, histology, so histologically they present the same, clinically will present differently. So histologically you will have sawtooth, rete ridges, a dense, dense T lymphocytes, degeneration of the basal cell layer, and then also thickening and keratinization of the epithelium. Lichenoid reaction, though, will be like asymmetrical if it's local, so if it's caused by like contact to gold, amalgam, or composite, or it could be generalized due to a medication. So you wouldn't look at the medical history and you would find like NSAIDs, antihypertensives, I think anti-malarials and diabetic drugs as well. And then, as we said, lupus erythematosus will be presenting in the mouth like lichen planus, but on top of that you'll have like rashes and then other autoimmune diseases as well, so you always check for autoantibodies. And I think that's it. Cool. So I might do another one. See you later. Bye.